Welcome everyone. Thanks for attending today. This is the second National Conservative Kidney Management Working Group, and today we are expecting about 35 confirmed attendees, a few tentatives. So thanks everyone for joining us online today. I think that will help us to avoid many of our technical challenges. So again, please continue to let us know if you have any issues with sound or visuals after the meeting. Chelsea is standing by for support should you need it during the meeting. And we do have some IT technical support on hand too. So thanks everyone. So similar to last time, I'm just going to kind of go through a little bit of housekeeping. We do have a presentation to begin with. We also have a couple of presenters, Dr. Sarah Davison. We have a patient advisor who I'll introduce later on, and we also have Dr. Nasrallah who we'll introduce later on. So after the presentation, we will be opening again for a discussion period about halfway through. And this time we will start in the west and we'll work our way east. If you don't have audio, then please do type your messages into the message board within Link, and I will ask you when we're ready to take your question. I'll repeat it, and there will be a response and discussion afterwards. So there is a couple people that were able to join online that couldn't get access. So those of you that are online, you know who you are. Once again, we'll collect some feedback after the meeting. So we'll just move on to give a quick overview of the agenda. Based on some of your responses from the last meeting where we asked you to kind of summarize your challenges and your priorities, we have outlined those and we'll review them. We will then move on to the presentation portion of first portion of this meeting around choosing CKM. We'll start with a caregiver journey, followed by a demonstration of the patient decision aid, and then that's when we'll open up for group discussion. Next, we'll look at priority focus areas that this group will be moving forward on, and some discussion around working groups, and then we will wrap up with another discussion around how to move forward and next steps. Now I'm going to pass the presentation over to Dr. Sarah Davison.
Thanks, Kirby. So welcome, everybody. Absolutely delighted to have you all here. So as Kirby said, based on all the feedback that we received, and thank you to so many of you, not just for the feedback during our last discussion, during the meetings, but all the feedback that you provided in the it's been extremely helpful. And really there was a lot of consistency in terms of the identification of challenges, concerns, and I think most of us were, even though we have very different contexts and we practice in different areas of the country, there's a lot of similarities in the challenges we face. So they were really around areas of how do we best support our patients, patient education materials, but also a lot about how do we support our staff in providing CKM and the education that is required to support the multidisciplinary healthcare provider group. There was a real wish to standardize terminology and practices, those core elements, like what is CKM? And then really in terms of operationalizing CKM, not forgetting that we have our community partners. one of our key areas is going to be making sure that we have key patient engagement throughout this entire process. This is about the right care for the right patient. So although we've identified patient engagement as a priority area, it's a priority area in of itself, but it also spans each of the individual areas of CKM as well. And that's going to take a lot of focus of this group to make sure we keep that patient engagement going throughout everything that we do. The next thing was really staff education, and this was felt to be critical really early up front in the work that we were doing. And then we need to develop the guidelines and the core pieces of CKM so we can standardize it. So our healthcare providers really do understand the nitty-gritty of the type of care that we are going to be providing. And through all of these first three priority areas, really the importance will be true collaboration and sharing of resources and our expertise so we can all benefit from this work and no one's feeling like they're working in a silo. We're going to leverage our national collaborative. So they were the top priorities, and then not forgetting that we really want to find optimized ways across the country of bringing in our community care providers as well. So in terms of our general mechanism of how are we going to do this, so it's our how-to, it's our general approach as we address these priority areas. So we heard consistently from you that there's great need for educational tools for both patients and healthcare providers, and that we need a systematic approach to applying these tools in clinical practice. So we will always be looking out there to ensure we've done a full inventory and we're aware of current CKM content and current resources that are already available and create awareness around those resources. And they may serve as our straw dog. Then it's a matter of we are going to have to divide and conquer for much of this work. So we're now beginning to work on forming sub-working groups around these first priority areas, realizing that those priority areas, as we develop them, they will shift and they will evolve. And that each of these groups will then identify what are the unique barriers and facilitators within each of these areas. What do we already have? What are still gaps in the care? Are the resources that we have sufficient? What do we need to do to improve them? What do we need to create? And then really solicit, bring that back to the group, solicit feedback, test some ideas, as we start developing our tools, then we can refine them. And then ultimately implement those changes locally and get feedback. How are they working for people? So where we're going to go now is, although we're going to be talking about in the latter part our focus areas, we are going to spend a chunk of this session today really talking about facilitating the CKM conversation for many reasons. This was one area that it's an issue about communication around conservative kidney management, and it was very clearly, it spanned a couple of priority areas, as you'll see in a moment. It spanned patient education, patient engagement. It spans healthcare provider education around a critical component about getting the right patient on the right care pathway. So we're going to focus our first part of today's session on this. And we're going to hand this over to Vivian Bethel, who's going to share her experience with you. So Vivian, thank you so much. And I'm going to hand this over to you. Okay, so I tell you what we'll do. We'll allow Vivian just an opportunity to get back online. While we're waiting for Vivian, I'm just going to go over some of the issues we have in terms of identifying those patients that perhaps might be most appropriate for conservative kidney management. And first of all, we have to understand that when we talk about conservative kidney management, it is a treatment modality that comes with a lot of complicated, can be quite complex care. So as we're going through this next part of the presentation, I want you to consider a few questions. So when we get to the tools and the patient decision aid, I want you to think about how the existing patient decision aid potentially could be used locally. What would be the barriers to using it? What might help you using it? Or what would you need to do to adapt it or enhance it for local use? So is the content appropriate? Are there things that are missing? Or even if you think the tool's reasonable itself, are there things that you would need other educational materials to actually be able to use the tool properly? So would you need to actually train people on appropriately facilitating conversations using it? And ultimately, what is missing from a patient or caregiver or healthcare provider perspective? What is still missing in terms of supporting those difficult conversations? So these are some of the things that I want you to think about as we go through this. So just keep in mind, I want to show the survival of incident patients starting dialysis. The main issue is many people, even when they are very, very supportive of conservative kidney management, tend to view it as something that is predominantly appropriate for older patients. Or they make decisions saying, well, I've got a patient that's in their 80s, and so therefore conservative kidney management must be appropriate for them. And what I want to share is that this is actually not the case. We have some older patients, as we know, that can do really quite well on dialysis. It is not just about age. So while you have someone in their 80s, about 50% of them will have died after about a year. And someone in their 70s starting dialysis would have died after about 2 years. But this is all patients. This doesn't help you determine who would do better on dialysis versus conservative kidney management. I mean, absolutely, your survival advantage might be a little smaller the older you are, but it doesn't actually mean that you won't have a survival advantage. So I don't want you to think that decisions are going to be made just because you hit a certain age criteria. So if we look at the majority of our older patients, so those starting dialysis around 70 years of age, the fact is the majority of them are going to have a survival advantage. But the conversation is probably going to be around what kind of life is it that you want to live. So that survival advantage that we would see when you compare conservative kidney management to dialysis, a lot of it is going to be time spent at dialysis. They're going to spend 4 times, likely as much time in hospital. So really their hospital or dialysis-free time is now getting smaller and smaller. So that dialysis or that survival advantage becomes more limited. And then and that's just taking into consideration age. So we then want to layer on other aspects. What about cognitive function, physical function, symptom burden? These are the things that are really going to be making that we're really going to have to consider when making that decision. And the reason is our elderly patient population are so heterogeneous, and really all our patients are. So while our reality is maybe most of our patients that start dialysis may look a little bit more like this gentleman than this robust woman who's out there hiking in the mountains, but the fact is we have patients that are more robust and will do well. It's a matter on dialysis. It's just a matter of identifying who they are and who's going to do poorly. So in terms of our patient population, those with poor functional status and those with cognitive dysfunction, we know tend to do particularly poorly. And unfortunately, the numbers, the older we get, the more likely we are to have functional decline and cognitive impairment. And the numbers are quite alarming. And these are the patients that we need to identify that are likely to do less poorly. And we know there are those who are going to do, who will likely do better on a conservative approach compared to those who would start dialysis. So the next part, I would now like to actually demo the patient decision aid. So just keep in mind that we know some things are really poor predictors of doing well on dialysis. And for example, this one study that came from patients aged 75 years of age or older in long-term care do particularly poorly. And when you look at their functional status that year before starting dialysis, so that's that graph at the left and that blue line, you can see that they were really quite stable for most of that year before starting dialysis, and that's that dotted line down the middle at 0. And really around the time of preparing them for dialysis, whether this has to do with hospitalization for access creation, or we can only speculate in this retrospective study, but they start to decline with a very rapid decline in the first month or so starting dialysis. Then they sort of plateau, and then they have this sort of just a progressive decline following that. And when you look at the cumulative mortality immediately starting, it's extremely rapid. So the bar graph at the right, if we just look at the bottom there, by 12 months, about 6 out of 8 patients have died. Only 2 out of 8, so a quarter, are alive, but 1 out of 8 has lost functional ability. And we're talking about functional ability of basic activities of daily living. They were already pretty poor functional status to begin with, and only 1 has been able to maintain that functional status. So clearly dialysis was not able to provide a lot of benefit in terms of survival or functional ability for this patient population. And the other thing to keep in mind is that choosing CKM, it is not about choosing life versus death, because choosing CKM does not mean imminent death. It's a decision about how they wish to live their life rather than life versus death. So if we take it from a decision around about GFR of 15, so stage 5 CKD, we know that many of these patients progress quite slowly. And so they are losing residual renal function slowly. Many of them are going to die before they will need dialysis, regardless of their decision. And so in this retrospective study, the numbers are just quite illustrative. But this was an observational study. And if you look at those at 1-year survival, the CKM, still 68% of them were alive at 1 year, and at 2 years, almost 50%. Now, those that chose a dialysis, sure, they had a survival advantage, but really the CKM patients were not rapidly dying. And this is keeping in mind that these patients were older, they had much more comorbidity. They picked CKM for a reason, because they had greater burden of illness, and they still had a survival of close to 50% at round about the 2-year mark from a GFR 15. So I just want you to keep that in mind. So when we go to the patient decision aid, when we're having these conversations for our patients, what we want to keep in mind is that we really want to balance a few things. We want to balance their values, their preferences around many aspects of what might be important to them. Their ability to travel, their commuting time back and forth, control of their time, whether they want to stay out of hospitals, surgeries, all of those things absolutely do play a role. Some more important for patients than others. But prognosis is also going to be critically important, and it's not just about survival. It's about how am I going to feel? How am I going to function? They want to know overall quality of life. They want to know their symptom burden. They want to know how they're going to be able to function as well as their survival. So as we go through the patient decision aid, these are the factors that that are currently built into the patient decision aid that we will be weighing. So I am just going to stop there for a moment to see if we have the ability to have Vivian come back on at this point.
Yeah, Vivian, I'm just going to give you a chance to speak up if you can hear. Okay, great. I'd just like to introduce Vivian Bethel. She's one of our patient advisors on this group. Vivian is retired as head of human resources from the Bank of Canada. She's currently the chair of the Southeast Regional Renal Patient and Family Council based in Kingston and a member of the Ontario Renal Network Patient and Family Council. She also sits on the Ontario Renal Network's Palliative Care Priority Panel and its 2 working groups. So today, Vivian, I'm going to turn this over to you so that you can share your journey as a caregiver for your husband, Jerry, and how you became involved as a patient and family advisor. Thanks for joining us, Vivian, and I will hand it over to you.
And thank you, Kirby. That was a wonderful presentation, and I think I'm going to reinforce a lot of what you have said, Dr. Davison. So I'm just going to give you a little background on my interest and participation in what we refer to in Ontario as comprehensive conservative renal care, but of course in Alberta and other places it's called conservative kidney management. So in 2016, shortly after the death of my husband from renal failure, I became a member of the ORN's Palliative Care Priority Panel as the first and still only patient and family advisor. My motivation was basically to become a caregiver voice for improved palliative care. But you can probably guess what my definition of palliative care was, and many people still believe this. I thought of it as end-of-life care, and what a surprise. I was quickly introduced to the broader aspect of palliative care for CKD patients, and it became obvious that my perception of palliative care was not aligned with the panel's. So this is what I learned. I learned that palliative care means care for people with life-limiting chronic diseases such as CKD, and includes, as you well know, but I did not, such important aspects as symptom management, shared decision-making, psychosocial support, spiritual care if desired, and other care, not directly related to treating the disease itself, but it also means that this care should be introduced at an early stage of renal disease, and that planning for the future is an important incentive for doing so. It means having what has already been discussed, having conversations about values and beliefs and desires and what's important going forward, and substitute decision makers and wills for personal care and potential outcomes, and how they will be supported as the disease progresses, as well as a myriad of other things. So I learned a lot. I began to appreciate the importance of having serious illness conversations early in the course of the disease, preferably before a diagnosis of end-stage renal failure, and of collaboratively planning for the future. I'm still vitally interested in improving the quality of end-of-life care, but basically as an add-on to palliative care. So there are two working groups for the priority panel, and both of which I sit on: shared decision making and conservative care, or comprehensive conservative renal care. In this latter group, I have learned about who among the CKD population would most benefit. As discussed earlier, they are patients with end-stage renal disease who have several comorbidities, who are frail, who may be elderly. In other words, those who are seriously ill. And there are others, of course, as Dr. Davison pointed out, who choose this modality and who probably could have other options, such as a transplant. But it is my understanding that the majority are seriously ill and are choosing between dialysis and CKM, and you can correct me if that is incorrect. So here is my husband Jerry's story. He was diagnosed with cancer, multiple myeloma, in 2013, and shortly thereafter his kidneys failed. And as an aside, he also had an artificial heart valve and some damage to his heart during surgery, plus the complications of Coumadin. So he ended up in the ICU, not only with renal failure, but also with sepsis, and dialysis began in the ICU. Because he was a crash start for dialysis, and because of that, we were woefully uninformed about anything renal and of the treatments available. We had no conversations with nephrologists about treatment options, his wishes for treatment, his values, and of course possible outcomes. The only discussions I remember prompted by us were about how long he might expect to live, and estimates varied by specialist. We had no idea that dialysis may not have been his only option. He almost certainly would have chosen conservative care had it been offered as an alternative and had he understood it. He did survive for 3 years, although his health was very fragile, and dialysis was an ordeal for him and for the rest of the family. So as this formerly strong and able and intelligent, and I'm somewhat biased, very independent person became weaker and less able to look after even the most basic personal needs, he became, as one might expect, increasingly despondent, and he dreaded those onerous trips to the hospital for dialysis. He had so many uncontrolled symptoms: pain from compression fractures, severe dysentery, cognitive decline, probably from the oral chemo, many infections, the majority of which were acquired in his many hospital stays, hematomas from overcoagulating him, eventually heart failure. The list goes on. There was no quality of life and no hope. He kept saying that he needed and wanted to die. I strongly believe that if advanced care planning and goals of care conversations had been held with us, and he had been given an option of conservative care, his quality of life would have been considerably improved. As well, and this has been confirmed, I think, the data I've seen on life expectancy for seriously ill renal patients, those with comorbidities, seem to indicate that there is little difference between the two modalities. More importantly, conservative care is a much less invasive and demanding treatment, as I understand it. Eventually, after a conversation with a young nephrologist who told him that withdrawing from dialysis was one of the more dignified ways to die, I would challenge that, but he made an immediate decision to do this, and we as a family accepted without question his decision. As I keep saying, he had no quality of life, and it was his decision to make. He wanted to die at home, and we made arrangements for that. But the supports that we expected and needed were not often there. The lack of resources was obvious. But that's another story. And I do keep thinking that there must be a better way, and I'm really excited to be part of this initiative. So I'd be happy to take any questions if you have them, and thank you for this opportunity to tell our story.
Vivian, thank you so much for that story and really keeping things right at the forefront in terms of what is so important. It's our patients, it's their priorities. Thank you. I'd like to open it up if anyone has some questions for Vivian. Vivian, can I ask you a question? If you had one question or one point to make to that first nephrology team that was caring for you and your husband, what would be that message to them? What would you love to be able to tell them today?
I'm not sure I have messages. I just have so many questions. Things that I still don't really understand. Maybe I could throw out a question. Can I kind of turn that around?
Absolutely.
I'm wondering if there is there no possibility, because I keep hearing this, that once a person is on dialysis, they can't move to conservative care. And let me just continue this a bit. In my husband's case, he was a crash dialysis patient. And so, he had a line and he was immediately on dialysis. But if his condition had, his kidney function had somewhat improved, could he then have gone on CKM?
So great question, Vivian, and we actually hear it a lot. So yes, he could. The problem with starting dialysis, when patients start dialysis, and especially those that are more chronic, they tend to lose residual kidney function over time. And so then if you stop dialysis, we tend to call it withdrawal from dialysis because your survival now has tend to be shortened because you really have lost residual renal function. And so that's very different than someone never starting dialysis. However, when it's acute, and if there is some renal recovery, so if your husband did have a little bit of renal recovery, so he had a certain amount of residual kidney function, maybe around that 6-7%, somewhere in there, then if he could have stopped, yes, and then been maintained on a conservative pathway. So that would have been an option. Some people, though, when they're acute, they lose their kidney function completely, and in which case, if they stop dialysis, their survival may be in terms of days or weeks because they don't have that residual kidney function. It all depends if they've got the residual or not.
Yeah, thank you. I really appreciate that. I have other questions, but
yeah, we will spend lots of time talking after. Thank you so much, Vivian, for sharing that very difficult personal experience. So what we're going to do right now is I'm going to take the next 15 minutes or so, and I am going to demo the patient decision aid. So this is the CKM pathway on ckmcare.com, but the bit that I want to demo is the patient decision aid, keeping in mind those questions that we talked about before. I want you to think about how the tool might be used. What are your barriers and facilitators to using it? What's missing? What else do we need to facilitate these conversations? And we'll open up for discussion. So if we click on the patient decision aid, the first critical piece of information is to highlight to our patients and to script it for our healthcare providers that dialysis is a choice. And that not only is dialysis a choice, but dialysis may not be for everyone. It doesn't cure kidney failure, but it certainly, we hope that it might help you live longer and feel better. But how you're going to do on dialysis very much depends on your overall illness now. So just exactly as Vivian beautifully highlighted. But again, it is their choice. And that through using this tool, we're hoping that we might use it as an educational tool to facilitate those conversations for patients to be able to determine whether dialysis or CKM might be right for them. So if you click on treatment options, this would be like any other treatment decision aid out there. So basically it has to show all the key aspects of what CKM is, what dialysis is. So if we click on how does this treatment work, we've got what is a description, a very brief description on CKM, but you can click here to learn more and it'll take to the CKM booklet where they can have all the resources on what CKM actually is. And then it briefly explains what your dialysis options are. Other things, these two are critical. How will I feel and how long will I live? So these right up front, it's just beginning to set the stage that overall how you feel and how long you're going to live with each of those treatment options really does depend on your current kidney function, your current health status, other health problems. So it is beginning to just try and get people thinking that really the healthier you are, the better off you're going to do, really, on no matter what you pick. Then the rest of it would be things that you would normally expect to see in a kidney education class. So what are some of the side effects that you might expect? How much time will this treatment take? So it talks around what PD is, what hemo, you need to be on it 3 times a week. It goes through surgeries. For peritoneal dialysis, you need a catheter. Hemo, you've got options for a fistula or a line. Conservative kidney management doesn't require surgery. Who will do my treatment? Will I need special training? What about food and fluid restrictions? Do I need equipment at home? All of these things are explained in a mobile-friendly manner with links for more information for some of them. And lastly, can I change from one treatment to another, or can I change my mind? And absolutely, you can change your mind, although all options may still be possible. And obviously that depends on when you change your mind. So the next piece, though, is really about prognostication. It's about how will I feel and how long will I live? So the first thing it's going to ask you are there's key aspects which we know predict outcome on dialysis versus CKM. So I'm going to weigh this heavily towards CKM just to illustrate some points. But we're going to say, yes, we live in long-term care. And when you click on that, you'll see that the infographic automatically pops up. And this is, because it's a learning opportunity, it's a discussion point where that if you are older than 75 and you're living in long-term care, because this is just the data that we have, that the vast majority, unfortunately, will not have survived a year. Those that do, almost all of them will have certainly lost additional functional ability. So it's a discussion point. The next thing, do you suffer from dementia or cognitive impairment? Because this would be the next key thing that would really indicate a poor prognostic indicator. So again, we're going to skew it yes. We don't have numbers yet, and we don't have good Canadian or any international data on this, and we're collecting it. And hopefully within the next 2 years, we'll have similar infographics to show. But what we can say, and again, it's a discussion point, is that when people suffer from dementia or cognitive impairment, dialysis often makes them more confused. So dialysis is almost never a good choice for people with dementia or significant cognitive impairment. So again, discussion point only. We can't, we say almost never because we don't understand the patient's value system, their religious or cultural beliefs. There are other things that may come into this decision. And obviously, tools like this can't account for a skilled facilitator or someone that might not be presenting this information in a more sensitive manner. Now, we are going to bring age into this because this does make a difference, albeit it is not the main predictor. Let's just say we've got someone in their 70s. What this is showing, this is the infographic I showed before, that really throughout most of the ages, if it were only age that we would take into consideration, there's still usually a survival advantage with dialysis, but the older we get, the smaller the survival advantage is, and that survival advantage increasingly is taken up with time on dialysis and time in hospital. And ultimately, if you layer on the other things like cognitive impairment and functional status, then we lose that survival advantage, or the benefits may not be sufficient to outweigh the burdens. So the next two things, though, are key. And they're about comorbidity. And again, we're coming back to functional status. So not just living in a long-term care facility, but I want to know, how would you describe your overall health? And we bracket it into three different categories. One, you could be able to take care of most of your needs. You might need occasional assistance, but really you're doing at least most of your basic activities of daily living. So you can bathe, dress, feed yourself. You just may need some help with grocery shopping, cleaning, that sort of thing. Or you could be the opposite end of the spectrum, and basically you're needing substantial help with your basic activities of daily living. So you are spending much of your time lying down in bed or needing excessive help. And then you've got the group that's in the middle that needs quite a bit of assistance and frequent medical care. So let's say we're going to put middle of the category. Again, we're working on the infographics that will actually give numbers to compare, but until we have really good quality data, we can't show it. We can only go on what the current literature would suggest, which doesn't give us numbers, but it's a discussion point. People who do best with dialysis are people who are functionally independent. So if you spend much of your time in bed, or if you find you need help with day-to-day chores, and again, it's like those activities, those basic activities of daily living, like dressing, bathing, dialysis probably will not help you much, if at all. And then lastly, it's those comorbidities. So you can have few comorbidities, or you can have many other health problems. And then there's another category. Even if you're actually quite robust, but you do have a significant heart disease, then that is its own category and risk factor as well. So let's just say we've got someone who's relatively robust. All of these infographics are taken from a GFR of 15, so I want you to keep in mind. So it's really around about the time of conversation, not the time that you would have started dialysis. But if you can see, there is a survival advantage with dialysis. But basically, most patients are going to be alive at a year, regardless of what modality they've picked. They've got minimal comorbidity. They're likely progressing slowly. And I bet you most of them actually haven't started dialysis yet. So what about if you say, don't have a lot of comorbidities, but I do have heart disease? We start seeing the survival advantage for both groups, or the survival for both groups, decrease significantly. So it's decreased for those who choose dialysis, and it's decreased for CKM. It is a significant risk factor. And the survival advantage, that added benefit for dialysis, is smaller now. So the window between the two numbers has narrowed. Again, though, keep in mind that more than 50% of patients will still be alive at a year, even with heart disease. And again, this is taken from a GFR of 15, though. And these are data for patients 70 years of age and older. They're the caveats. But what about if you've got someone, and these are many of our patients that have multiple comorbidities. This is exactly as Vivian had pointed out, so her understanding was correct, that there is really limited survival advantage with dialysis. But again, I want to point out that more than 50% of these patients are still alive at a year's time. We can care for these patients after making a decision for CKM for often many years. So for Vivian's situation, her husband probably had a GFR of less than 15 when he started, crash landed in dialysis. But for those patients that we have the privilege of seeing sooner and having those more timely conversations, it shouldn't be as frightening a conversation to have. So most of them can do reasonably well. So they're the prognostic indicators. Then we come down to what matters most to patients in terms of lifestyle preferences. And there were 4 factors that really came up from our patient advisors and in the literature that was really important. So one was, how important is it for you to avoid being hospitalized? Most patients would tell us it's actually very important. What about having major or minor surgery? I'm just going to say, well, it's important, but it's kind of, you know what, I can handle a surgery if I'm going to do okay. So maybe I'll rate it at 3. And this just defines what surgery is. How important is it for you to avoid traveling for dialysis or a clinic visit? So this can be critical for patients. So in Alberta and much of Canada, because we are a large spread out country, we have patients who will have to relocate for dialysis. And our elderly patients in Alberta said that they were willing to give up a median of 9 years survival in terms of to avoid hospitalization, not realizing that their median survival was actually only 3 years. But many of them also spend a good hour and a half traveling to a satellite unit, or even if it's just half an hour, 40 minutes, they're waiting for their DATs and then or their transportation to dialysis, and they've got to go to a clinic. So it can be very disruptive. So we'll say, just for this case, I'm going to say it's fairly important. And what about control of your time? What do you want to do with your time? Do you want to travel? Do you want to see the world still? Do you care if you're told, I have to do dialysis on a Monday, Wednesday, Friday? Or do you want to be able to say what you do and when you do it? So say, you know what, it's actually fairly important for me. So they were the factors that patients came up, and there may be more factors that we need to consider. So here we can complete and review. So on the summary page, and this summary page can be emailed to family, to themselves, it can be printed. Again, it's just going to be a very brief definition of what dialysis and CKM is, and it's stressing that the survey results are only based on the answers that you put into this tool. They're highlighted in orange, the pathway that might be more reflective of your responses. We have got 2 sections, my well-being. So in medical speak, that would be your prognosis. But for patients, it's their well-being. And it's their well-being in terms of quality of life, function, survival, and symptoms. And then what matters most to them in terms of control of time, surgery, hospital, and travel. So the way I answered it here, and keep in mind, I've biased it strongly towards CKM, quality of life. We can actually talk to them through that quality of life is actually, if they're cared for appropriately, that their quality of life is anticipated to be quite stable on CKM, really up until the last month or 2 of life. And at that time, they're likely to feel more weak and may lose interest in the details of daily life. Whereas if they choose dialysis is not likely to make them feel better, and the side effects and burden of dialysis may actually even lower their quality of life. So please keep in mind, this is not what I would tell every patient. This is what I would be telling this patient that's sitting in front of me, because I put them as long-term care. I said they've got cognitive impairment. I said they need major assistance in their daily living. This is for the patient that I actually put in as. Their functional ability. Their level of functional ability is likely, again, to be relatively stable until the last month or 2 of life. But for this patient sitting in front of me right now, that he or she is likely to lose functional ability probably quite rapidly after starting dialysis. And only about 13% of patients like him or her were actually able to be alive and maintain their functional ability at the end of a year. What about their survival? Because I put functional long-term care in, it sort of trumped everything else. But basically, CKM, his or her lifespan is likely to be the same with CKM than dialysis. And some people like them may actually live longer with CKM rather than starting dialysis. We never know who those people are that are going to die very rapidly within the first 3 months of starting dialysis. And that dialysis is unlikely to keep them alive longer. And then we talk about symptom burden. And again, for this patient sitting in front of me, they need to be aware that symptoms are common with CKD, but the severity of their symptoms that they're currently experiencing right now are likely to be stable until the last months of life, or the last month or two, and that we're going to focus quite aggressively on treating them, and most of them can be treated. Things that we struggle with are that fatigue, that loss of appetite, maybe some nausea. There are symptoms that we tend not to do as well with. Whereas with dialysis, symptoms are common again with kidney failure, but their severity of their symptoms are not likely to improve with dialysis. And in fact, for this patient sitting in front of me, the dialysis procedure I'm going to anticipate would likely worsen some of their symptoms, specifically things like the fatigue, the post-dialysis, potentially things like muscle cramping. So then we get on to the other aspects. What about what matters most to me? So control over time, I'd answered it saying, I want control of my time. Well, it still brings up the issue of peritoneal dialysis. So if I'd answered slightly differently in the first prognostic area and my patient was a bit more robust, then you know what, PD might be a really good option for them. What about surgery? Well, I actually said I didn't really care too much one way. It wasn't a strong factor in my decision making. So you see it hasn't actually highlighted anything here. It's just giving all potential options. Hospitalization, the only data we have right now, which is unfortunate, are the data that you've currently seen that CKM or dialysis is likely to spend up to at least, well, about 4 times as much time in hospital. And then if we go down to, and then with hospitalizations, we can see that with conservative care, we'll spend less time in hospital. So I'm not going to go over the other frequently asked questions. That's just the treatment option piece that you saw right at the very beginning. But I want to take you to the additional considerations, because this is key in facilitating these conversations. And if you're already thinking about some gaps in this patient decision aid, I suspect they're here. So what about, actually, I lied. Let's just go back. Let's just see if I can navigate this here. Survival. I actually forgot to show you something here. At the end of survival, we do give a prognostic indicator for short-term survival, because I was just about to talk about important milestones. You will have those patients in your practice that are prepared to put up with substantial symptom burden, functional decline. They have a really important milestone that all they care about is meeting, whether it's the birth of a grandchild, a wedding, or there's just, for whatever reason. And so this is based on a 70,000 patient US data set. We had them rerun their prognostic indicators based on our factors here to calculate the 6-month expected survival. So just to keep that in mind. So now we'll go back to additional considerations. So asking your patients, are there other things that are really important to you? So such as milestones, but what about spiritual or cultural beliefs that are not necessarily built into that first piece of the decision aid? How do they feel right now about their options? Do they know enough? And then what about the reasons for conservative care or their reasons for dialysis? So if they're already beginning to think of one modality versus another, having them sort of reflect on that and articulate can be quite important. And do they actually have a preference for right now? And how strong is that preference? And they can rate that. This next piece is critical though. So how many of you have started patients on dialysis or having those conversations where the patients are choosing a modality based on their preferences of their loved ones? So they're starting dialysis because that's what their children or their spouses want them to do, whether it's because they haven't accepted their reality, they're in denial, or they're just not ready to say goodbye, whatever that is, or they don't fully understand the burdens associated with dialysis. So we ask them to name who's actually involved in this discussion or this decision with you, and does that person have a preference? Put it down there, and then we ask them, are you feeling some pressure from them? We give them that permission and that platform to actually articulate that. And it's not judgmental, it's factual. Are you feeling some pressure? And then to ask them to reflect, how can that person help you decide? How can they best support you in that decision? And then at the end, are you ready to take action? Do you need to learn or do you want to learn more? And then there's a space where they can type in other questions, thoughts, reflections. Then they can save it. They can email it to themselves, they can print it, or they can then bring it to their, email it to family or bring it to their clinic visit. So I am going to stop there. And I am going to open this up for some conversation.
Great. And just while you're doing that, Sarah, we have Nancy Verdon on the line. We can take a moment to introduce you to our patient partner, Nancy Verdon. We've been working closely with Nancy for a couple of years now on a number of different projects. So Nancy, I'll just let you take a moment to introduce yourself and how you got involved.
I'm Nancy Verdon. I've been a dialysis patient for 31 years. That has included a crash start on dialysis. I was originally diagnosed when I was 12, when urinalysis was developing a standardized measure of quality of urine, etc. I was untreated until 1988 when I had a crash start on dialysis. And I am thrilled to see the changes that have happened in the system since then. At that time, I was admitted through emergency. That was a Saturday night. On Tuesday, I was handed the Kidney Foundation binder and told I needed to decide what dialysis I was going to be doing by the end of the day because they were going to do the surgery on the Thursday. So that was pretty overwhelming, to say the least. The good news is I actually am a health practitioner. I'm currently a retired occupational therapist, so at least I spoke the language and I had some things like that on my side. So I did start dialysis. I went on PD. I've had 3 failed transplants, and now I'm a happily retired person and very, very involved in this current research. I started as a recruitment for the Kidney Health SCN in Alberta, which I've thoroughly enjoyed. That has led me to an invitation to be a part of this project, and I thank Sarah very much for the acceptance and the opportunity to participate. I've also been trained as a PACER researcher, so looking at patient and community engagement, something that has been invaluable in helping to bring the patient voice to most of the projects that I'm involved in. I'm able to look at what are the patients really experiencing in addition to questionnaires and surveys that they're doing. Needless to say, over the last 31 years, I've had my own complications from being on long-term dialysis, and the opportunity to be a part of both CKM and this current project with advanced chronic illness with multiple comorbidities has really been near and dear to my heart. I think this is a key opportunity to make sure that our patients are getting, the patient's family and their support system are getting the care, quality of life. But also what I'm hoping for is that we're going to get a good voice from our care people, so as our doctors and other people, that looking at the whole picture, looking at the opportunity to make it a truly team-coordinated, collaborative program to get everybody involved so we get the best quality right the way through. So thank you for the invitation and the opportunity to participate. I look forward to being more involved.
Thanks, Nancy. So we're going to just open up for discussion. We'd really like to hear from everyone that's on the line. We've kind of posed a few questions here to help lead the discussion, which you can see up on your screen. And I might just start with, we have had a couple of messages come through the instant messaging. So I'm just going to start with a question from Janice Melanson. She's asking, is the decision aid something that is offered through a medical appointment or online and available more broadly? I wonder about the computer ability for the older population that might be considering these options.
Great question. So the patient decision aid is freely accessible. So it's had to be created realizing that people can access it with or without an experienced facilitator. And that comes with a bit of responsibility in how we put the information out there. I think most of us would agree the best scenario would be to actually walk through this patient decision aid with a skilled facilitator that actually understands the content, as well has the skill set to be able to have that conversation in a manner that is very empathetic and supportive for the patient and is able to really pull out what's most important to that patient. That would be obviously the gold standard. But the reality is patients wanted access to this. They want to be able to take it home. They want to be able to read it through or work on it with their family members. So basically anyone can do it at any time. So the more feedback we get, and as we learn on our prognostic information and we're able to get more granular detail, that's going to be very important to really integrate that in a tool, realizing that they may be doing it without any medical support. We know that right now, most patients don't actually know it's there until they're introduced to it by a healthcare provider, but that might not always be the case. Oh, and then the computer savvy part. What's interesting is our elderly patients are using the computer more than we anticipated that they would, but really this is not built necessarily for especially those with cognitive impairment, the more frail, ill patients. It's typically their loved ones are walking them through this. So when they go home, they've got someone with them doing it. There's usually someone within that support system who's accessing the tool with them.
Great. We also have another comment from Janice McKenzie, who says at the U of A hospital, we often go through the decision aid during an appointment. So I'm not sure, Janice, if you want to share anything further with the group.
I think in my experience, if you take a little bit of time, go through that decision aid properly, then the patients and family really understand why they've made the decision, and they don't tend to change their mind even if they get quite a bit of pressure. So I think it takes a little bit of time to go through and well worth the effort in my experience. My favorite part of the whole pathway.
Thanks, Janice.
Okay, so there's no more questions coming up on the instant messaging. So I'm just going to start in the West and open the conversation up to the BC folks. So if anyone has any comments or questions from BC, please go ahead. Okay, moving through to Alberta. Janice Clemens, I might just put you on the spot as one of our other few patient advisors that are on this group. I was just wondering if you've had experience with any of the tools that have been shared with you, or if you have any comments or things that you'd like to share with the group, and don't feel like you have to, just giving you the opportunity to speak if you'd like. Any comments from folks in Saskatchewan?
This is Jan Clemens phoning from Alberta. I thank you very much for inviting me to join the group. I'm honored that I can be a voice. I'm quite, my situation is much different from the other Alberta patient in that I was on dialysis for just a year and a half, and last year received my transplant. So, but I look at this kind of a lot through the eyes of a daughter with my dad that went through dialysis a little bit in a bit different situation, and all of the guides from what I can gather, the guides that you take families through, patients and their families through on life expectancy, comorbidities, freedom of their life choice and time at the dialysis center versus at home. I just think it's a really well put together guide for patients and their families to make that decision whether they want to do dialysis or conservative care. And I just hope that it will be readily available to all patients. Through peer support call, I took a call from a gentleman from Medicine Hat that had decided on conservative care. His family was very much against that decision that he had, so it was very difficult for him. But as a peer support, I certainly honored his choice in making that call, and wish, when I look at your slides that you have and how you can guide a family through, I wish this would have been available for him a few years ago there in the Hat, just to point out the pros and cons of all the choices that a patient goes through.
Thank you so much for that, Janice. Appreciate it.
Thanks, Jan. So anyone else in Alberta, and then I'll move back through Saskatchewan.
It's Myrna Potker.
Hi, Myrna. Go ahead.
Hello. I just want to say that the beautiful thing about conservative kidney management and this tool is it sort of normalizes the fact that it is a patient's choice. So it's part of our modality teaching. It's a treatment option, and as you use the decision aid, all that information that is found in there, it just lends itself to almost having an advanced care conversation about what they would want. And it's just been amazing to use it and to see the benefit that it's been not only to patients and their families, but also to us as staff who are using it, because the information in the whole conservative kidney pathway is amazing, and we've certainly seen the benefit to us as users of it, but definitely to our families and patients.
Thank you, Myrna.
We do have another question from Saskatoon. I'm not sure who it is. I'll read out the question. It says, this is extremely helpful. Are patients pre-selected by nephrologists and then get slotted into a CKM options class during CKD clinic? So I guess, Sarah, you'd be best or to speak to that.
Yeah, no, so our philosophy, at least here in our program is that we want to build core competency skills of all our nursing staff within the Advanced Kidney Failure Clinic. So all our nursing staff they do modality teaching, and they are trained to be able to recognize patients that are likely to do better on one modality versus the other. But they need to be trained in doing modality teaching for all four modalities, whether it is PD, hemo, transplant, or CKM. And so they will raise this issue with all patients. And to be perfectly honest, while the nephrologist, I would hope, would have that conversation as well, they do. It's often initiated probably earlier on by the nurse first. So no one is getting slotted into a CKM stream or anything else. It's just very open, honest conversations with all patients to understand what modality is best going to meet their needs. And only when they make that decision do we then start the care pathways. I hope that answers your question. Thank you.
Yes, great. We have a question from Sushil, a nephrologist from Manitoba, who says, we currently have no existing CKM program and are very interested in developing one. Any suggestions in starting a new program, and how would you suggest we can adapt decision tools for local use?
So, great question, and that's what this whole process is about. So I'm hoping when we get into the next part of the presentation, I'm unfortunately going to have to move on soon, is that it's all going to be exactly addressing that question. How do we take these tools and adapt them for use regardless of where they are in the country? Some of the tools that we have now that we collect across the country are actually ready to be used and can be used. Some are going to have to require adaptation depending on where you are, but until we have those conversations about everyone's discrete or unique barriers and facilitators, it's really hard to understand. But as an example, you can use that patient decision aid now. If that's a tool in its current state that's helpful for you, it's freely accessible. So there are many tools that are available, and part of this process is just really creating awareness around that. So, Kirby, in the interest of time, I'm going to have to, I think, move on so we can sort of get through the rest of the meeting. But what I would really like to stress is we need people to start thinking really quite strategically about these tools and critically about these tools. I want to think, so first of all, for this patient decision aid, because it's one of the tools that's quite unique and it is freely accessible. So we're going to be sending out a survey to each of you, and if you have other people in your care teams that you can solicit feedback from as well, we'd be happy to send them a link to the survey in addition to yourselves. But we're going to be asking you to think reflectively about this PDA, this patient decision aid, which might mean you have to go on it and play with it a little bit. But you know, can you use it now, or how could you use it now? But what might be the barriers to using it? Or are there things that you need to help facilitate its use? Are there things that need to be changed in it? Is it missing content? Or is there additional content you would love to see put in? Or even if you like the tool in its current version, do you need help in the implementation because you need education around how to use it? And how would we provide that education? Would it just be an online educational module, for example? So these are the types of questions we'll be asking, along with usability, you know, just the visual appeal from a patient perspective. Are they able to easily, and a healthcare provider perspective, navigate it? So that is going to be coming, and we're really going to be begging for your input on it. We can't improve the tools and we can't meet your needs if we don't fully understand what they are. So leaving it at that, I'm going to move on to the next bit, which is to really highlight our key priority areas. So these were the key priority areas that we're going to start with that came out from all the feedback we've had since the first working group meeting. So there are really issues around patient engagement, about staff education and training, and about guidelines. So the specific content of how, like, what is CCAM? How do we deliver it? We are going to be doing this work by dividing and conquering, as I said before, and setting up working groups. So the way that we would like to set up these working groups is that we will have one member from this core research funding team to, along with another co-chair from the national group that will work as in tandem to chair these working groups. And basically, you'll be using the individual from this research group as your facilitator to do all the administrative pieces, set up all the meetings, the coordination, all the legwork. So the rest of the team really has the time to put into the brain power of the project. So we're working with Vivian and Nancy, who we're hoping, time permitting, will sort of tag team to chair our patient engagement strategy with their backup coordinator being Kirby. For staff education and training, the Betty Ann Wazalenik, who's our nurse educator on our team here, very experienced in kidney supportive care and CKM. She'll be working with someone from the national group. So we are still looking for someone from the national group who might be very interested in co-chairing this work with Betty Ann. And then for the guideline work, I'm going to co-chair that on this side, along with a grade methodology expert. So we have to identify that individual first. And the oversight will be provided by the CSN Guideline Committee, which is chaired by Jihad right now. So early on in the process of guideline development, Jihad will be providing that grade expertise that will then be handed off to another methodologist as we get further into the process. So just to highlight what some of the issues about the patient engagement priorities might look like, and I'm saying might because there were very few patients involved in this first round of information. So a lot of these priorities were set by non-patient individuals. But really what has come up as potential areas of focus for this group is really helping patients understand their health. So part of this is treatment options, and that's where the patient decision aid comes in. But it's also understanding their illness trajectory and transitions in care from functional living as they transition to that more terminal, pre-terminal phase of life. A huge area we feel is probably going to be self-management, and that's really come strongly from our patient partners, so that's our past experience, and that self-management really focusing on symptom management, their crisis management, what do they do when all hell hits the fan, and that personal goal setting, which is really something that we're hearing time and time again, and then that support for family and caregivers, that patient shared bereavement, and other gaps in resources. So these are some potential areas that we patient engagement work will likely focus on for the first year at least. And for tools and education materials, we already have some resources, but do they need changing? As we move from an Alberta focus to a national focus? Are there gaps missing? Also the branding, the focus, this now needs to evolve from what we've got at a provincial level to a national level, and bringing in all the other pieces, that the work that's happening elsewhere. So for example, and Vivian, you may be able to provide some insight on this. Our symptom patient handouts went to Ontario for the empathy study. And I know Mike Walsh, along with his group there, had got quite an extensive patient stakeholder group to look at the patient handouts to provide additional patient feedback. It's this type of thing that we need. So now they've got an Ontario version. We need to sort of get our national version where we get eyes on it from our patient and allied health representatives from all provinces across the country. Then staff education and training, the focus areas that have come up loud and clear, very consistent about that conversation. So really around a patient decision aid, but core elements of CKM. So that will be the guideline work, but it's also how do we operationalize, and what about community resources and support to our community care providers as well as our families. And then advanced care planning. How do we teach people to do this well? So lots of things to think about in terms of educational modules, and how do we deliver that at a national level? When we're talking about skill-based, it's basic competency. All right, and then for guidelines, I'm going to hand this over to Jihad, because Jihad will be outlining our process for the next priority area, which will be guideline revisions.
Thanks, Sarah. Just in the interest of time, I'll just sort of provide a very quick overview of this, this guideline development process. GRADE is a guideline development framework that was born out of efforts to harmonize the way that people develop guidelines and incorporate best evidence into guidelines. And over the last decade or two, it has essentially been established as the gold standard methods framework for guidelines, and it's been adopted by a number of national healthcare organizations, even internationally, WHO and others, and it's sort of a growing list of GRADE users. So there are lots of resources and best practices that can be applied. And there are additional layers to GRADE that involve the development of decision aids. And so we'll eventually, as we dive into that work, once these guidelines are developed and we want to go to translating them into the decision aids or updating the patient decision aids that Sarah and everyone has spoken to already, there is some great guidance around how to do that, and so we can leverage that sort of best practice. In terms of this slide, and just by way of a quick overview of the method, you can sort of conceptualize the GRADE process as two major phases of work, and the top panel, the blue, being the process of developing systematic reviews that would inform a guideline. And that box is kind of self-contained. If you're developing a systematic review for any topic in healthcare, you can follow the GRADE systematic review framework from end to end, and we'll end up with a very robust product. But if you want to then go on and develop a practice guideline, then that's sort of what the lower panel in red speaks to, and that's the phase where you've assembled a panel, a representative group of individuals with content and methods knowledge, and who can bring patient and provider perspectives from across the board, and they will have a set of materials developed that will help to inform the decisions around the actual recommendations. But that panel is also instrumental in shaping the systematic reviews right at the very outset. And so what that looks like is, and just at a high level, is that that the panel will begin with a set of clinical management questions. So, some of the questions that might be addressed that were spoken to earlier would be a decision to choose dialysis versus CKM. And then each question you would begin with a patient population, an intervention, comparator, and then a range of different outcomes. And so the panel would choose a number of outcomes and then would rank those outcomes in terms of level of importance. And it is those highest ranked outcomes that will be really important in formulating the guideline and in how we interpret the evidence surrounding that outcome. So essentially what follows is a series of steps where the various management or clinical care questions are prioritized, the outcomes are prioritized or ranked, and then a series of systematic reviews are conducted. And in our case, there's already a fair bit of work that has already been done. So a number of systematic reviews that were done some time ago that will feed into these guidelines. And in many instances, all that we will need to do is actually refresh those reviews with updated literature where it's available. And the grade framework then provides some software and tools for summarizing the evidence addressing those questions and appraising the quality of the evidence, essentially determining how believable that evidence is and how confident we can be in these summarized results when we go from translating these results to clinical practice recommendations. And so then once the information is summarized in these so-called evidence profiles, the next step is to take into consideration some of the other factors that determine how recommendations are made. So it's not just about how important the outcome or the question is, but also how high is the quality of the evidence, how confident are we, how do we make trade-offs when there are benefits and harms with different treatment alternatives, and how do patient values and preferences tie into those trade-offs. And that's really critical in developing decision aids. So in a very straightforward scenario, you might have a therapy that works in all populations, is very safe, and the quality of the evidence is really high, and a guideline committee might say that they would issue a strong recommendation based on high quality evidence, and that therapy, that intervention would be applied across the board with little hesitation. Unfortunately, in this particular content area, this area of decision making, the values and preferences are usually a more important arbiter of clinical decision making, patient preferences, as opposed to the effectiveness of a given therapy or treatment alternative. So the balancing of benefits and harms, the trade-offs and the values and preferences, that information is really critical in developing the guideline, which then goes into developing the decision aids. And so that's obviously a very important piece here. We'll spend a lot of time on that. So that's sort of a high-level overview of how GRADE works. And maybe I'll just stop there. And I think that as this work evolves, we'll obviously get into more of the details of how each of these steps will work. But I'll just quickly say that we will plan to. I think there's a subsequent slide that outlines our next steps. And at the conclusion of this call, we'll be reaching out for expressions of interest from anyone and everyone here on this call and involved in this work, and would definitely welcome anyone with prior experience. You don't necessarily have to be a GRADE guru or expert, but if you have some familiarity with GRADE and are willing to share that knowledge with your peers, we'd certainly love to have you on the working group. And once we have put that panel together, we'll aim to have a short but formal training session sometime in the early new year. And in the background, we'll start to, Sarah and I will work together with the identified panel members over the next few months to start some of the earlier phases of the work that are not so technically demanding, but are more geared towards identifying what the clinical questions are that we want to focus on. So I'll stop there and maybe now take questions. Thank you.
Thanks, Jihad, for that. So are there any questions? I'm just going to open up quickly if there's any burning questions for Jihad. Certainly, if there are, you can please type them into the comment box. And then I've just got a quick question for you, though, G. Deb Zimmerman just emailed me as well and asked if you could potentially give an update from the CSN executive meeting that you had. She said, or your CSN board meeting in Washington, that she said you were very much supportive, and currently a lot of that discussion was around hosting the tool website or on your CSN website outside of the members area. That's sort of what we've been talking about. Yeah, if you could maybe provide a brief update for us.
Sure. So at the last CSN board meeting, at the last CSN meeting in Montreal, the board unanimously agreed that this was an important topic to adopt as a CSN guideline, and that the CSN would help to put some resources in place, whether it be disseminating the guideline or other tools through the website, or other mechanisms. I think all of that has yet to be determined, and we have to sort of figure out, how that fits with what you've already done, et cetera. And I think she was just asking me to provide an update in Washington of where we land following this meeting. And so we can certainly do that.
Oh, yeah, you're absolutely correct, G. Yeah, you're supposed to update her in Washington. My apologies. Okay. Okay, perfect. Thank you. Thank you so much for that. So in terms of where we're planning on having our initial focus for the guideline work, we know that through grades, some of the clinical areas will be managing the CKD care and the complications. So things like, how do we change the CKD guidelines? So you'll see all those on the pathway right now, but we have to sort of make sure that our guidelines, as we go through the grade process, remain the same or consistent. So the management of hyperphosphatemia, acidosis, high blood pressure, statin use, all of those. How does that change for a patient that has chosen CKM? Then, of course, we've got our focus on symptom management and what are we able to pull together in terms of our symptom management guidelines. And then what might not be grade necessarily, but this is where we'll have to work together. There will be guidelines around what constitutes the core components and how do we best operationalize. This will be a little bit more difficult to put into a guideline potentially, but around the crisis planning, the need for advanced care planning, those pathway processes that bring in our acute care and community provider referral processes. This is the nitty-gritty of how to actually operationalize things. So we're going to have to address those as well to actually help programs develop them and put them into practice.
Sarah, can you just clarify for those who don't know, there was a question that came in, what grade actually stands for?
Jihad?
That's a grading of recommendations, assessment, development, and evaluation.
Thank God you were there.
Thank you.
Yeah. But it essentially speaks to how we grade, how we standardize the grading of recommendations, and it comes from the earlier annoyances with the different grading systems that were very unintuitive, where you'd have letter grades, Roman numeral grades, grade 3, subscript A, and so on. And the part of the goal with creating this new standardized framework was that the grading was very simple and intuitive. It's either a strong recommendation or a conditional recommendation, and it's either based on high quality evidence, moderate quality evidence, low quality evidence, or what have you. It's just very user friendly and easy to implement. Sort of the genesis of the name.
Thanks.
Thank you.
So just as we're wrapping up here, prior to our final questions, I want to give you at a high level where we're at with current timelines and deliverables. But we are now at the second CKM meeting in September. We are hoping to have all the working groups established with them fully understanding their scope of work by November, into November. And then really we are needing a draft of recommendations, the work, and the bulk of what they're going to bring back to the committee, really by the end of February or mid-March at the latest, because each of those working groups will then be presenting to the national group for discussion, input, to be able to go back, make some refinements, so we can actually present at the CSN for wider stakeholder input. And this will form sort of the our initial step out of the gate of initial thoughts on resources that we can provide, realizing that we've still got, we've got a lot of time into the project, but we want to be able to have concrete deliverables that we can share with the rest of the CSN community and broader by May of next year. So in terms of the working groups, each, as I said, will have co-chairs. That the expectations, they'll provide the leadership facilitation and accountability to the full committee. And one of those co-chairs will come from the research group, who will be responsible for all that coordination and all the more administrative, messy, time-consuming work. I think it's really important that we have provincial representation on each of the groups. And Kirby's going to be working with membership from each of the province to try and get you to think as a provincial group how you can best divide and conquer amongst yourselves to divide yourself between the three groups. That comes from patient advisors as well. Our patient advisors are there to advise, support, and engage other patient and local patient networks. And we're hoping for at least 1 to 2 from each province. So we can have representation not just on the patient engagement panel, but also a voice on each of the other panels as well, or working groups. And then we'll bring in consultation, such as a grade methodologist as required. So where you're seeing holes, it might be a matter of saying, Sarah, I think we need expertise in this area. Can you maybe go out and look for it? And we can certainly do that. And then, of course, administration. This group here is here to provide that to the best. So I am going to now just open up for any, in our last 15 minutes or 10 minutes of the meeting, feedback, questions, comments, clarification about where we're going. And I do have one slide next on next steps. So Kirby, I'll hand it over to you.
Yeah, sure. Maybe we'll start out east. If anyone has any comments from Newfoundland, Nova Scotia first, please speak up.
PEI.
PEI, yeah. And then moving through to Ontario, where we know we have a larger group. Any questions, comments? Manitoba.
Hi, it's Dawn from PEI. Yeah, we're just really excited to be a part of this. We just had our nephrology day the other day, and certainly it was identified that these issues are pretty important for our province. And I actually am a social worker here with our nephrology program, and I did a discussion on sort of some of these serious discussions that we need to be having. So this tool looks really, really, really exciting, really promising. I feel like it would be very empowering for patients for them to partner up with us and so yeah, we're just really excited to be here and looking forward to kind of hearing more about how we can work together to develop this tool. So we're on board and ready to help in whatever way we can.
Thanks, Dawn.
You're welcome.
Anyone else anywhere on the East Coast? Okay, and Central Canada, Manitoba, Saskatchewan. There is a comment that came through from Ruth DeBoer, who mentioned that CANT is taking place in Edmonton in October, and was wondering if there might be more of an opportunity to have more of an informal gathering of some of the individuals from this group to meet face to face within, during the CANT meeting.
Ruth, I'm really glad you brought that up because I think that is an opportunity. I'll be at CANT presenting as well. If there's interest, perhaps you can contact myself, Kirby, and with a CC to Ruth, and maybe we can look at getting a group together, even if it is just informally, to take some, just to have a chance to meet and to take the conversations a little bit further in a way that's just face to face. I mean, I think we need to take those opportunities where they arise. So, yeah, let's keep that on the table, Ruth.
Okay, any other comments coming through? Saskatchewan, Alberta. Love to hear from anyone on the line. Okay, and please do feel free to continue to ask questions. You can email me. We will be providing a follow-up to this discussion. Like Sarah said, with the evaluation form that's going out, there was a revision to the timeline in the presentation that was circulated, so we'll send an updated timeline, and I will hand it over to Sarah just to review some of the other next steps for this group.
Yeah, so really just last slide, last couple minutes of the meeting, folks. So what we're going to be doing over the next couple weeks, Kirby is going to be working with each of you, really sending out emails probably at a provincial level. So to really try and work with you as provincial groups to identify who would like to be on which working group. So we really want you to work within the areas that you're most passionate, obviously, but we do want to make sure that we have good representation on each of the 3 priority focus areas. And then we're going to help work with you at setting up those scopes within which those groups are going to be working and scheduling your first meetings. So really, we'd like to have all of those groups well defined by November and be able to work with you. So by November, end of November, you've had your first meeting, you understand your scope of practice, and your group is fully formed. Keeping in mind, the goal is a preliminary reports for our next meeting, which will be our next third national meeting, which will be late February or early March. And we will be, in the next little while, we will be sending out doodle polls to try and get that date marked in your calendar sooner rather than later. And where we will have each of the working groups really start presenting their work, the nitty-gritty, where they want to take this, what revisions are required, what the needs are. And we're hoping to have that work relatively well advanced by that point. And that's our job, to work with each of these working groups to really help facilitate their productivity. And then that will allow us not a lot of time, but a little time to tweak our reports based on the feedback from the national group. So we have materials that we can present for stakeholder engagement at the CSN. So at a very high level, that's what we are proposing. So we will be in contact with you very soon in terms of getting those working groups set up. And the other thing is, that's not on the slide, but I talked to earlier, is that there will be a SurveyMonkey, or there'll be some survey coming out that's really going to ask you to play with the patient decision aid and reflect on it and provide some very specific feedback for you. And if you have colleagues, patients, family members, or there's other people out there that you think could provide really good feedback for us, if you could round up a few of those and send us their contact information, we will also send the survey to them. So I am going to leave it there and sign off. A huge thanks to all of you that have hung out to the bitter end of this. 2 hours is a long time for a meeting. And please just be in contact if you've got additional thoughts, reflections that you felt you weren't able to share with us at the meeting today, or things that just popped into your head. And I'll just leave it there with a huge thank you.